Hi there, it's Rob Arnfield speaking to you. I'm one of the attending physicians in the CCTC and the Director of Junior Resident Education at the ICU, and we're looking forward to having you at your upcoming ICU rotation. This screencast is going to cover some of the housekeeping and administrative aspects of your rotation so you can hit the ground running on day one. The CCTC site itself is a large mixed medical surgical ICU, in fact one of the largest in Canada, with 29 beds sprawling over 5 different bays, and with a neighboring trauma observation unit, which many of you will be familiar with, which houses moderately ill trauma patients whom we are not directly responsible for caring for. However, you will often see patients transferring back and forth between the ICU and that call environment. There's a few different call lines. There's a sense of first call, which is really the main team looking after the patients, and that's the team you're going to be on. But to provide critical care, it's a complex team environment, and so there's other teams, often those who focus specifically just on the ventilation needs of the patients, as well as a team that manages CCOT and provides critical care to the ward patients as well. There's a ton of different people you're going to meet, and ranging from the consultants, of whom there's very few, to the bedside nurses, of whom there's very many, upwards of 200 in fact. And you'll spend a lot of time with the bedside nurses, and they have an enormous amount of training and experience, whereas you often come in with less experience, but a lot of good medical knowledge. And so often that duality of you two together forms a good combination. And so working with them closely and respectfully will be a big part of your rotation. And the allied health members, we have physiotherapists, pharmacists, dietitians. You may be accustomed to working with them up on the wards, but ours down here, they're a special group. They're extremely well trained, and in particular, you also work with respiratory therapists in a new way that you haven't before, because they help with the ventilators and can certainly help you with airway situations and a lot of the areas of knowledge that are growing for you on this rotation. Every morning there's going to be some form of teaching, and so your teaching attendance at these teaching rounds is mandatory, and ultimately you'll see there's a broad array of the teaching topics as well as the teaching formats. Occasionally there'll be things in the afternoon, including quality improvement rounds, and once a month there's ultrasound rounds, which I'm particularly partial to, which you keep your eyes open for. Ultimately, these kind of topics will round out the multidisciplinary and very broad skill set that critical care requires, and I think you'll find quite enjoyable and useful. Now, really importantly for you is every Friday there's CCTC grand rounds, which are done by you, and each resident will be expected during the rotation to present once on a Friday morning, and typically you'll choose a topic that will intersect with your base specialty and critical care. So if you can think of how critical illness intersects with your specialty, you can start making a short list for the topics you might present during this hour-long session, with the talk typically being somewhere between 30 and 40 minutes, so you can allow lots of time for discussion, which is always the mark of a good talk, is if there's lots of discussion. So think about how you can engage in debate and ask questions and make it interactive, and that'll make for an excellent presentation. Now, there's morning teaching, as I've mentioned, and sometimes that comes at the conflict of other priorities, such as sick patients. So if you're on call and there's a sick patient, obviously patients come first. If you have home program teaching, generally you'll be free to go to that rather than our own morning program teaching. And you are often expected or better off to do some rounding on patients prior to the morning teaching so that you can attend and be undistracted by the need to do the morning rounds. The format for the ICU day can vary by consultant. There's two different approaches that have been attempted and are being used. Some we currently call the trial format and a traditional format. The traditional format is sort of a monarchy where there's a single consultant for the entire week, and one team is overseen by the one consultant. And there's a second format, which is more of a hybrid model, where there's, I guess, an oligarchy where there's two consultants, and the teams are split in two, and is a bit more bedside intensive for morning rounds. And right now we're just sorting out which the best method is. It may be that by the time you do this rotation, only one of these methods will be the prevailing method. So be prepared for either method, I suppose, based on current indecision regarding this. So So you can see here further detail of how these rounds will work. So in the traditional format, handover rounds are done in the large conference room, and all disciplines are present, and it's a really organized fashion of communication. And the new format that we're trying is more bedside driven, and it makes use of the workstations on wheels to tackle some of the CPOE issues that we have that are new. And so you'll find each method has its strengths and each method has its drawbacks as well. Ideally, before you do your morning rounds, every patient will be assigned to one of you, and you will know which patients are going to be yours, so that as you arrive at the patient bedside or each patient is spoken of, you know particularly which patients and which action items are yours to carry out. And this is in keeping with this. And this will spare you the somewhat overwhelming scenario of trying to keep track of all the action items of all the patients in the unit. In addition, in morning rounds, you'll want to be attuned to the fact that it's not just a doctor-driven unit, of course, and you'll be listening to the input from the respiratory therapist and the bedside nurse in particular regarding the care trajectory of the patient. Now, day to day, you're going to have maybe multiple patients to manage. You're going to have to prioritize them in sequence of the ones you feel are most sick or have most urgent action items. And you have to get in the room and examine the patients. The patients are often sedated and can't voice their concerns to you. So you have to get in there, you have to look at the ventilator, you have to examine the patients, you have to really figure out, go looking for problems, because they won't necessarily present to you the same way that your patients can readily do so in a ward environment. In general, you have routine availability to your senior and your consultant to discuss plans and orders. And as well, because of the complexity of the care the patients receive here, we ask that all patients who leave here, whether it's upstairs to the ward or downstairs through a celestial discharge, you will have a little bit of dictation to be done to account for the transfer of care in some cases. Or just a quick summary of the patient's stay if they do indeed pass away. At the end of the day, we do another rounds, and the point is not necessarily to summarize all the complex issues of the patient, but really just to hand over what anticipated issues are overnight, which calls on you to synthesize what are the most active issues, and to really arm your colleagues who will be grateful for your advice, who, if they haven't seen that patient that day, for you to be able to tell them what you anticipate the calls might be and the issues may be, and it allows the team then to discuss what the appropriate solutions would be in an anticipatory fashion of those kind of problems. So the handover rounds in the evening are designed to be efficient and really just arm the on-call team with the tools and the solutions they'll need to deal with the most likely problems. It goes without saying that when you're on call, I mean, you're going to carry a great responsibility. You're extremely well supported, however, both by each other. Usually there's two of you on, as well as by a senior and your consultant, and the charge nurse is a key player in all of this. So introduce yourself to the charge nurse. The charge nurse is really in charge of organizing the resources of the unit. New admissions should always flow through them, so they can assure that every patient coming in sick will have the nurse they need with the skill set they need to manage their particular issues. The other thing to note is that you may not know that respiratory therapists are trained in airway management and are frequently very, very capable airway managers and can sometimes rescue you from difficult airway situations. The real escalation for a difficult airway, however, is always the anesthesia consultant or resident who is always in house. So you always have backup for airways if you're worried about airways. We encourage you to take it very, very seriously, but you always do have some backup. And anesthesia is also expert with access, though again, your senior resident should ideally be available to help you with non-emergent intravenous access as well. You should review new admissions with your senior resident at the time of arrival, so that you don't get behind in resuscitation or issues aren't missed, and you'll just really want to keep in good contact with them and striking a good working relationship with your senior on each night of call, figuring out how they like to do things, how they like to round, how how they like to be contacted, text message or pager. All these kind of things are just normal parts of the workflow. And as always, you can call the consultant directly if you cannot reach your senior or if there's problems. You will carry the code blue pager and the pre-arrest pager as well, and you will, while this may seem intimidating, we will review some of these details in greater detail, and it's a team environment. No one expects the ICU resident necessarily to come up and single-handedly save the day, so if you haven't been involved in many codes, fret not. However, again, this is your opportunity to think about cardiac arrest resuscitation, to refamiliarize yourself with your ACLS protocols and drugs and CPR and all these kind of things. So ideally you'll get sufficient exposure to these problems without feeling as though you're overwhelmed by them. And we can help with the education around that, as well as to support you for debriefing afterward. Procedures you'll be doing in the unit, which is good news for many of you who like to do procedures. There'll be some sheets you'll fill out with each procedure documenting the ease and quality of the insertion of whether it's a central venous catheter or an arterial catheter. And the nurses may prompt you to fill out these sheets, and I'd ask you that you courteously respect their reminders, and ideally they shouldn't have to remind you. Those sheets are included in most of the our line insertion trays or nearby on the procedure cart. So please comply with that. And as always, the nurses in our unit are the gatekeepers, the ones who maintain the day-to-day continuity and quality, whereas you and your other juniors will come and go. So please be respectful of their obligation to sometimes gently request or remind you to do some of these things that may not be routine for you or you may not otherwise be familiar with. Infections kill a ton of people in our ICUs all the time. Often they come in infected, but sometimes they acquire infections while they're with us. We do know that hand washing is such a basic measure, is a life-saving thing. We encourage you, and I will audit you on your washing in and washing out technique. So when you enter a patient room, you should put some alcoholic solution, and on the way out as well. We have C. diff, we have multi-drug resistant organisms all over the place, MRSA, and imagine your loved ones in the bed next door, and they want you to have clean hands when you come from the previous bed with an infected patient. So please be mindful of that. It's good practice. And as well, we try and prevent other things in the unit, of course. We prevent central line infections by using maximal sterile technique when inserting lines. We have special dressings to prevent these things. Ventilator-associated pneumonia, there's basic things that we try to do to prevent that, including head of bed elevation. These basic protective things rather than these heroic interventions that you imagine doing to save someone's life. It's these little gestures of protection that actually quietly save lives and have improved the patient care and patient care outcomes in the ICU over the past 20 to 30 years. And in that keeping, universal precautions are generally mandatory for all our procedures. If in doubt, just become maximally sterile and gown yourself up. And there's central lines in particular. We have a central line screencast that will take you through some of those fundamentals of becoming sterile. And we have a kit of sterile stuff that will simplify what can otherwise be a bit of a dog and pony show of you getting all dressed up. So some of the other preventative things we've mentioned, positioning the head of the bed to prevent pneumonia. Obviously, prophylaxis for DVT is critical, whether it be through heparin or through compression devices in those who have bleeding risk. Stress ulcer prophylaxis, just through some PPI, has been an enormous breakthrough in critical care management over the past 20 years. Nutrition, things that we don't often consider. The nutritionist will prompt you to start early feeds in all patients who are eligible, as there's improved outcomes with early feeding. Things like skin care and physiotherapy, areas perhaps where you don't have expertise. The good news is we do have experts on staff who deal with these things. With the vent, you may not have familiarity there. You can discuss with your respiratory therapist and your senior resident and consultant about that. Maintaining glycemic control, all these things, they aren't particularly sexy. It's not, it's not an emergency pericardiocentesis at 3 in the morning. However, again, these are the things that will make you a rock star in the ICU, in my eyes, the eyes of the other attendings, and certainly all the nurses. So please think about these little details, and a lot of the big stuff will take care of itself. So some last minute housekeeping things to discuss. Make sure you sign up for your Friday grand rounds. There may be some simulation sessions while you're on service as well, which are pretty cool. And if you're going to make changes in the call schedule, you have to notify the senior, copy the senior who's on your service, as well as currently the administrative support comes from Maria Silvera at 58777. That may change, and I'll update this accordingly if it does. Your sheets with the patient details, we don't want to find those at the Barking Frog or at Jack's or someplace downtown. So just make sure you dispose of them. Every year we hear a story about patient sheets being found somewhere they don't belong, and it's always a bad situation. You get emails from medical affairs, so you don't want to do that. So just make sure you put them away in the confidential bins and sign off from the computers as you leave. So those are basic good practice, confidentiality practices. You have a room when you're on call with a luxurious shower and bathroom. There'll be computers and a study space, and just keep all the medications out of there. Again, every so often we find, syringes and phenylephrine syringes and stuff just left in the bed, and the cleaners don't really appreciate that. You're going to have some objectives, of course, that you can peruse on the website that's shown here and should be distributed to you. You hopefully won't get an interim evaluation, but occasionally we have residents who struggle either with their medical practice, or more commonly it's often with communication issues and difficulty working in the team environment. And so if there are some problems, you may get asked, I may ask you to meet with me halfway through your rotation to see if we can tune some things up. And final evaluation is done with input from everybody in the unit, so the nurses, the respiratory therapists, everybody. So it's not just how you show yourself as a physician to physician. It's a lot of it comes from how you interact with the nursing staff as well. So and at the end of the rotation, ideally I'd love to meet with you face to face. Certainly if there are problems, and otherwise you'll likely just receive a collated summative evaluation from everyone's input through 145. And we'd obviously love some feedback as you come through as well, and you'll have a chance to evaluate us also. So overall, have a great rotation. This is a bit of a administrative and logistically heavy introduction. So the good news is the rotation will really celebrate the wonderful medicine that gets practiced in the ICU and the principles of resuscitation. And I think you're going to have a fabulous rotation. Most people really look back on their ICU rotation as one of their most formative rotations of their career, where they bond with other residents and they make the most progress in terms of being comfortable with acuity and sick patients. So you can be in touch with me at any time, and otherwise we'll see you out there and enjoy your rotation.